OR Manager is pleased to welcome you to today's webinar, OR Management During Times of Crisis, presented by Surgical Directions, a leading specialty healthcare consulting firm. My name is Iris, and I'll be the moderator for today's event. I'd like to formally welcome all the attendees joining us today, and also take a moment on behalf of all of us at OR Manager to thank you for all of your hard work and efforts on the front lines. Our May issue of OR Manager is focused entirely on the perioperative community's response to COVID-19. So please visit ormanager.com after the webinar to learn more. Please note today's call is being recorded. If you experience technical difficulties with the web portion of today's program, please email clientservices@accessintel.com. You can also refer to the links box located to the left of the screen. You'll see a tech help overview, and it's there for you to click on and view, which will not interfere with your viewing of the program. You'll see we've also provided a link to our May issue there as well. This presentation will last 45 to 60 minutes and will include question and answer opportunities at the end. You can submit a question at any time by typing into the chat box in the lower left corner of the screen and clicking on the send button. Please note your questions are not viewable by the other attendees, but will be received. Finally, please know that a copy of the slides will be made available to attendees after the event. It's now my pleasure to introduce today's speakers. Ann Cole is an Associate Vice President of Perioperative Nursing for Surgical Directions, and Yvette Stanley is the Director of Consulting for Surgical Directions. Both speakers have significant experience working with hospitals and ASCs, helping them solve complex business and clinical problems. Ann and Yvette, welcome to the program.
Thanks, Iris. During the first part of our presentation, I'm going to focus on the business aspect, while my colleague Ann will talk more about the clinical aspect later. Today, we want to address the how and the what as it pertains to the landscape of surgical services post-COVID-19. I'm sure of one thing, and that is that while you've been on the front lines of your hospitals and your ambulatory surgery centers, your families have made many sacrifices. And I'm sure you never thought that in our lifetime we would experience such a thing as this pandemic. I salute the dedication of your frontline healthcare workers all over the country. And while you've been on the front lines, my colleagues have been given a lot of thought about our recovery planning and the essential framework necessary to launch cases post-pandemic while ramping up your elective cases. So in talking about the how has COVID affected surgical services and the financial performance of hospitals and ambulatory surgery centers? And what should hospitals and ambulatory surgery centers be doing now to prepare to accelerate the recovery from COVID? What our new OR management tool has and is available is how to assist hospitals and ASCs prepare for restarting elective procedures. So let's talk more about how COVID has impacted. When the COVID crisis hit the United States, many industries were negatively impacted. Healthcare professionals and hospitals planned for pandemic for years. But up until COVID-19 actually hit the United States, we really hadn't experienced a storm like this. And so hospitals were reacting to spikes in ER visits. The ICUs were experiencing patients on ventilators more than ever imagined. PPE equipment challenges exist and still do now. Furloughs, and physicians were told that elective cases were to be put on hold. And so that has really impacted seeing office visits decrease by 50%, elective surgeries declining up to 70%. And so all of these elements have really impacted the hospitals and ambulatory surgery centers and created this financial crisis that we're experiencing today. So with that being said, there are elective surgery postponement, and this curve shows that the revenue has gone down severely, in some cases up to 60%. And the bottom line will continue to suffer because this will last for up to a year, 2 years, some people say 3. But what we're looking at is how can we bring cases back online and using those backlogs in cases in a way that we can effectively manage to bring revenue back up to some type of recovery performance metric. So we think about ramping up post-COVID-19. We want to consider that some cases won't come back to the hospital as originally planned. Those scheduled cases may be lost to other facilities. And as you can imagine, some patients are fearful. While we have all seen images on television of the PPE equipment, spacesuits, people on ventilators, and reports of physicians and staff being effective, and the American public is afraid. And that's just something that, we have to acknowledge that it's happening and figure out ways to address it. And Ann's going to talk more about how we can address those things as we move forward from the clinical aspect. So some of those elective procedures may even opt until next year. And people will say, well, I don't want to go in a hospital because I'm going to go into a setting that is less invasive, like an ambulatory surgery center. And then others will have lost jobs, been furloughed, which will lead to loss of insurance. So these are some things that are going to happen and that we cannot control. Others may be fearful of even coming back to work and then taking time off because they've been gone already for 5 weeks or more. So how can we board cases in the near future that will impact and to get to some sense of normalcy? So the COVID crisis has created a new exaggerated existing trend in healthcare. And it's causing us to re-examine throughput, our processes. What will we address to be the new norm of healthcare? And we'll talk about how we can address these challenges with processes and some great tools that will innovate the new norm for healthcare. And as I mentioned before, the trends of case volume may shift to ambulatory surgery centers, and we have to ask ourselves, what do we have in place, and what does the competition look like in my own backyard? Are we ready to deliver optimum care in our facilities? That's in both hospitals and ambulatory surgery centers. How do we prepare? So most performing hospitals have some governance structure in place to make informed decisions about daily operations of surgical services. And we recommend that you institute a recovery council governance structure. And that's something that needs to happen now if you haven't already done that, because that's going to be the foundation for you to make informed decisions. So you need to have key stakeholders at the table and collaborate to hear the strategy and participate in making those informed decisions thoughtfully yet rapidly. So now I'm going to turn it over to Ann so she can provide you with some detailed solutions that will help address from the clinical aspect. Ann?
Thanks, Yvette. I appreciate it. Thanks for covering the impact of COVID to the hospitals and the ASCs and our healthcare community. And right now what I'd like to do is talk about our road that we're on. We're on the road to recovery. We now know that our states are talking to us about possible dates when we can start bringing the elective cases in. We're going to start to organize ourselves. We should be organizing ourselves, talking about how we're going to begin this process. We should be engaging those key stakeholders, our physicians, our anesthesiologists, our nurses, our inpatient floor key personnel, because we will have patients recovering in the hospital, Central Sterile, pathology. So all those key people that really work with us in surgery, we should start to begin talking with them. We need to organize ourselves, create a system on how we're going to prioritize and schedule those backlog cases, How are we going to talk to our patients differently? How do we prepare them differently? How do we help them become comfortable in coming back into our hospital? And really the overarching goal is to really optimize our patients and have a safe surgical experience. Are there tools? Are there tools and processes that we can embrace to help us get through that? We have developed a 6P framework to help you think about how we organize ourselves, and we'll have a checklist and some tools that you can use, and we'll talk about that. But first, we really need to talk about the plan. So we need to develop a plan. We need to understand that as we start to think about bringing those elective cases in 2, maybe 3 weeks out, maybe longer, depending on your community and your state, we need to start talking about bringing those employees back. How is that going to look? How are we going to greet our patients? How are we going to discuss the new requirements and guidelines for testing patients? We need to know the policies and we need to know the regulations. And how do we have to modify our policies and guidelines that we have in place? We need to take a look at all those cases that were put on hold. Many of our patients were scheduled and then canceled, so we have a lot of our pre-anesthesia work already done. So we have to look at who will be ready for surgery, who needs further testing, who needs to be retested. We have to look at our processes, and our processes needed to be redesigned. Many of our OR processes in the operating room itself needed to be redesigned. And we've had help from AORN to make sure that we're all going to be safe. As we bring patients into the system on the day of surgery, the processes will look new, and they are new, and they are unique, and they will look very different to our patients as we greet them at the curbside and tell them that their family cannot go with them, that they are going to be alone in this whole process. So that's going to be very unnerving and fearful for the patients, so we need to talk about that. We need to talk about our protocols that will be in place to ensure that they are safe and we are safe as we greet them with our PPE on, that we greet them with perhaps a face, we will have face masks on, but some type of a shield that will further create that strange greeting when we normally embrace our patients differently. We have our PPE standards. Everyone needs to know those standards. We have to ensure that our employees coming back from furlough understand these standards. And then we have to understand the fear that the patient will have. I mean, they are the most important cog in this wheel. They see what's going on the television, and it is extreme what they're seeing. And that's not necessarily happening in all of our communities. Some of our communities have very little COVID, and the experience at the hospitals are not as extreme as that we see on TV. But that is what they're seeing, and that they think is the reality. So we really need to prepare them differently and help them understand how it's going to look on their day of surgery. So to help us through as an entity, to help us through as a hospital to work through all these different things that we have to do, Surgical Directions has developed a checklist. It's a preparedness checklist, and we divide it into sections, into 4 categories that make sense to us as clinical providers. How do we prioritize the surgical cases? How does the office communicate to us and schedule those cases? How do we prepare that patient for the procedure using a virtual if necessary and possible? And then how do we care for the patient when they come on board into our hospital, go through the PACU, and be discharged to home? So all those processes are going to look new and different to us, and so we're going to talk about that. Within our hospital system, we're going to need to make sure that we have COVID-safe environments for our patients. We need to look at how we're bringing them into the pre-op area. How are we greeting them from the curbside, or perhaps curbside testing is being done on them, and their family is going to remain in their car while they're having their procedure. So how do we make sure that these outpatient procedures are handled effectively. We are going to be asking our pre-op nurses to greet the patient at the curbside in their protective gear and bringing them right into the pre-op area, not into a waiting area. They're going to be cared for one-on-one immediately. Again, the family may be asked, and they will be asked, to remain in the car. Only those essential family members will be allowed to accompany the patient. The patient, again, may be tested at the curbside as well. That essential family member may be tested. We will be testing patients afterwards. We will ask that those caregivers be tested weekly also. So this will be new and unusual for the patient. We need to communicate that. We need to explain to the patients that we are going to be wearing PPE. We are going to ask those caregivers to be wearing PPE also. How do we create those COVID-free zones in our pre-op area, our holding area, and in our recovery areas? Those are all essential things that we need to start working on. We also have to partner with our anesthesia providers. They're going to be working with the patients to use multimodal pain management, avoiding opiates, helping those patients recover more quickly. We're going to be engaging in virtual follow-up with these patients and following them for a longer period of time. And then we also have to be aware that our OR is going to look so different for us. We have to plan and schedule our cases differently. The cases are going to take longer. There's going to have longer case times due to the ventilation requirements post-intubation. And then once the patient is extubated and is leaving the room, we're going to have extended period of time, sometimes between 18 and 30 minutes, depending on your facility, to allow for the air exchanges to make it safe for all those healthcare providers to come in and turn over the room. So we have this surgical checklist that you will have access to after this presentation, and you will have it emailed to you. And it's going to talk about, we're going to talk about all the key things. Pre-anesthesia testing. How is that going to be different? Many of our patients were already gone through PAT. Their H&Ts have expired. They're greater than 30 days. So those H&Ts need to be done again. Can we engage our advanced practice providers virtually to complete those H&Ts, and then with an update with our physicians on the day of surgery? How do we do that? Is our testing still valid? Do we need repeat lab work? So we need to contact the patients, do as much as possible, virtually, instead of bringing them into the hospital setting. We need to talk with our surgical schedulers in our physicians' offices immediately. We need them to contact their patients to see if they're still planning to have the surgery. Have they changed their mind? Have their insurance changed? Are they going to an ASC and not coming back to the hospital? What plans do the patients have? Do patients have someone to take care of them at home? So that needs to be reviewed also. Our surgeons will be working on their list. They know what patients need to be done. They will prioritize those patients. We need to be talking with them about their equipment needs, their specialty implants or things that they may need for those cases. Our revenue cycle partners will be contacting our patients to reauthorize and or pre-certify the patient, making sure that the financial impact is secure for the patient. Other areas that we really want to partner with and be aware of are our central processing partners. They too have had staff that perhaps have left, have shift changes. We will be modifying our block schedule, our surgical schedule, so they too have to modify their schedule to meet our needs, to provide those quick turns for us on equipment. So we need to really engage with them and be aware of that. We need to talk with our physical therapy partners who need to perhaps screen patients and work with them before they leave the hospital. We also need to engage our home health people for placement, and as well our IT partners so that they can help us reach our patients virtually. So let's spend a few minutes and talk about our workflows, because in the OR, we have our workflows, and they are going to be modified. So let's start with PAT first. As we plan for our patients, we've done a lot of calls, we've got their history, perhaps they've gotten clearances from their cardiologist and other providers. We need to recontact them and see if anything has changed. Has their health status changed? Does any further workup need to be done? Does any further testing need to be done? What COVID testing is going to be done on them prior to the day of surgery? Is your facility going to be testing at the curbside, or are you going to be doing screening at the curbside? So these things will look different. We have to understand that workflow is going to impact our pre-op nurses, and what support will they need to accomplish a safe, the safe onput or admit of that patient. Anesthesia will be working differently for intubating patients, making sure that they have procedure-specific risk mitigation processes in place. They're going to be communicating with the families and the patients differently. So we really need to understand those workflows as we interview the patients preoperatively and post-op also. We're going to be really dependent on using our data and analytics team to help us schedule these cases, look at them differently, prioritize, and re-look at our block schedule. And we'll talk about that in a few minutes. But really, the message here is that our workflows are changed. The workflows in the OR are changed. Our cases are elongated. Our case lengths are elongated because of the ventilation exchanges and the need for intubating a little bit more safely. So we have to allow for that when we're scheduling cases. So the norm that we have, in our systems, when we anticipate that a case is going to take an hour or 90 minutes, we're going to need to add at least 30 minutes, sometimes 45 minutes onto those cases. So our scheduling workflows are going to look different. Oops, let me go back one. Here are a couple slides that I'd like to share with you. I really like them because they are process maps on those four aspects of preparing the patient on our checklist that I'm going to share with you in a little bit or talk about in a little bit. So these key processes of prioritizing the elective cases, and then here is the office scheduling process. I really like this process map because as we work within our teams of our planning of scheduling these cases and then working with our offices, we can share this process map with them and help them understand what we are going to do and what we need to have them do with us to make this really successful. So you'll have this as part of your deck when we send it out. And then this next slide gives us a process map for the patient preparation and also the day of surgery process. Again, talked a little bit how PAT is going to look differently, prepare our patients differently. They will be testing the patient when they are at the curbside or screening the patient at curbside, making sure that it's safe for them to have the surgery. If not, we're going to be canceling and then rescheduling probably 30 days out as they become healthy. But really, we're going to look differently at the patient, and we have to prepare for that. We have to understand it, and we have to let our nurses know what is going to be expected of them. On the day of surgery, again, the pre-op nurse is greeting the patient, the surgical nurse knowing how to greet that patient in holding, having their masks on. Everyone's going to be in garb. The patients have to know that this is how we're going to look. They're going to see it as they travel through the hallways. They're going to be unnerved by it. But again, we have to prepare and we have to talk about how that's going to look. As we report off from the OR to the PACU, it is recommended that that same nurse take care of the patient through stage 1 of recovery all the way through discharge if possible. And that will mean bringing on more nurses to work in recovery as we work through those stages. So it is something we need to talk about, and it is the ideal stage. So if possible, we really want to embrace having that same nurse that takes care of that patient when they come through surgery and then all the way through discharge and instructions. So what I'd like to talk about here is a tool. a checklist tool to help us get through what we're going to be doing and taking care of our patients. How do we organize our OR differently now? How do we embrace those changes in the processes, and how do we adapt that to our surgical schedule? So Surgical Directions has taken our analytics team, and we looked at what the cases are at a client site for the past year or two. And then we take a look at what backlog cases the physicians have and incorporate all that in, utilizing the current block schedule and coming up with an analytic tool that can forecast what those individual surgeons may need, what kind of time they need, depending on those cases and case length, what surgeon group blocks may look like, what their utilization, and then comparing that to the hospital site's capacity, because our capacity has changed. Our providers may have changed, our nursing staff has changed, our anesthesia staff may have changed. Our case length is elongated, so we won't be able to do as many cases as we would have in the past. Our processes are slowed. So we have to realize that we can no longer do those cases that we thought we could. It will look differently for those surgeons, and we have to explain that to them. So let me see here. I'm sorry that those slides have changed. I'm going to move that up a little bit to be on that checklist one. Here we are again. Sorry for that. So again, case prioritization. So our physicians are going to prioritize their cases based on acuity. They're going to look at their backlog values, see which cases how they want to balance their day. We may look at what will be an opportunity to work on cases on Saturdays, perhaps Sundays. Are there physicians that may want to flip rooms? Do they have the type of cases that can be flipped? You know, are there cases that we can quickly process to alleviate the backlog? So taking all that into consideration, our analytics team has developed what we call functional block schedule for these scenarios. So it will take a look at what physicians need or perhaps need extended time. So their 8-hour day now becomes a 10-hour or perhaps a 12-hour. Do we want to work Saturdays and have days where we can give a surgeon 2 rooms and do those cases more quickly? Do we have staff that can be dedicated for these specialty days? Do we have those specialty staff that can fill in on those days? Staff will be working perhaps longer days during the week. Can they fill in on Saturdays? Are there, staff that can work the weekends depending on their family needs? So all that needs to be into consideration. But what we're saying is that we really need to use our analytics to help us plan and develop a great block schedule that can help guide us and open up the schedule for the possibilities. And then partner with our physicians to say, okay, here are the days, and here are the hours, and here's the staff we have, here are the surgical assists you may need, and partner with them to take care of the patient. And again, bringing on our anesthesia providers that can also provide them the support that they need for their services, partnering with our pathology and tissue person so that they know that these specimens are coming through. IR may be impacted, so we need to talk with them. So all these considerations of these key stakeholders need to be brought into this specialty block schedule. And talking with them ahead of time and planning is essential. Again, we're going to use our governance committee that we had established to help execute and guide us. Again, talking very frequently, at least weekly. We know we talk daily with each other. We huddle daily. We have our safety huddles daily in the hospital. But this team of the OR team really has to review what is going on in our ORs and talk more frequently. If any of you need help with this or would like us to help you, utilize these advanced analytics to prepare your, a functional block schedule for this intermediate time, we'd be happy to help you out and discuss it further. We're going to recommend that you develop a pathway to surgery document. It's more or less a communication tool for our patients that really outlines to them what the expectations are when they come to surgery to the hospital or whatever, or either the ASC site, what it's going to look like for them, what PAT needs to be done, how admitting is going to be calling them, or our insurance verifiers will be calling them. What are their requirements for the night before surgery as far as showering or prep. Patients should be given all that information on who to call in case they do feel ill and they're not going to come in, or if they have questions or concerns. Sometimes a communication tool can be emailed. We can talk to them, whatever will work best for you. But you should consider making a little video so you can give them the link and they can see your actual garb, what it looks like, the color, how it looks like, whether you're wearing yellow or blue, so that they are familiar of what's going to greet them at the curve. So really that's important that we start to embrace how we're going to be engaging with our patients. I'd like to spend a few minutes here to talk about our Central Sterile partners. They're the foundation for surgery. We partner with them every day, but really it's more important right now that we include them in on all of our plans, that we let them know that, our case grid, our schedule, our block time is going to look differently. Their lives have changed in Central Sterile just like the OR lives have changed. They too maybe have staff that are not coming back from a furlough, or perhaps they've been laid off and moved on to other jobs. Perhaps their babysitters have changed for their children, so they can no longer work days. They're going to need to work evenings or nights. So, as those specialty lead people in Central Sterile change, those specialty instrument assemblers may change. We need to be aware of that as we plan these cases in surgery. So it's going to impact us. Central Sterile needs to know if we're going to have a Saturday when we're going to do cases back-to-back in flipped rooms, or we're going to request quick turns. Central Sterile is going to have to prepare vendor trays differently, making sure that we have them in advance so that we can have them ready for those quick turns. So really partnering with Central Sterile is essential. Also, too, the Central Sterile managers need to realize what's the competency of the staff that are going to be working the off hours to accommodate the surgery schedule. Are they competent in the trays? Are the staff going to be ready to take on the volume of trays that may come in very quickly to process? So things will look different in Central Sterile. Include them in on the plan. And then this probably is a good opportunity for the managers and directors of surgery to partner with the Central Sterile managers to make sure that the staff is well trained and they do have the educational tools that they need, that they are competent, that they are certified. And going forward, do they need support? Do your managers need support in Central Sterile? We do have a lot of tools in surgical directions that can help Central Sterile and educate them and bring them through the educational process. So if that is something that you need in the future, we have that for you. So I'd like to talk a little bit here about communication. We talked about developing something for the families and for the patient to understand, updating them on what are the precautions, the preparation that the hospital is taking. You can be sure that they're fearful. We're hearing it as we go from hospital to hospital as we talk with our hospital partners. The patients are saying that they're not necessarily going to have surgery right now. They're going to wait. So how do we embrace them? How do we make them feel comfortable that we are taking the steps to make sure that they are safe, that they understand what we're going to be doing for the pickup process at the curbside, and how we're going to then send them back to their loved ones. They need to know that we are making the whole hospital safe for them. We know that there are going to be COVID patients in our hospitals, so how do we communicate to them that they really are going to be in a very safe environment, that we are going to have COVID-free zones for them, that they are not going to be next to a patient that, is diagnosed with COVID. How are we going to communicate that to them? How are we going to show that to them? How are we going to show them that we are keeping them safe by wearing our PPE and making them comfortable with this new environment? We're also going to need to let them know that we are going to communicate with them after their surgery. It's not just the day after post-op call that we're going to be making, but we are going to need to be in contact with them up to 14 days post-COVID, or post their procedure, We want to make sure that they are not ill, that nothing has, that they've not converted, that they are not sick, or any of their caretakers are sick. So we are going to be looking and talking to them about COVID symptoms on those phone calls and making sure they are safe. And also at this time, we really need to talk about communication within the perioperative department and within our hospital. We've been working very hard as perioperative leaders, harder than we've ever worked before, with doing less cases, but we're working harder because we're working on those protocols. We're testing the way that we're going to perform those surgeries differently. We have been working on processes and protocols, and we need to communicate that to our staff. We need to communicate to the staff the new life we have to live right now within healthcare. And more importantly, as we bring those furloughed and layoff employees back, we need to communicate with them differently. Many of them are very angry. They're very angry that they were the ones that were furloughed or laid off, and now you're asking them to come back. You're asking them perhaps to work different shifts and different days than what they were used to. So, they are in a process where they need to vent and understand, and we need to understand how they feel, because it will impact the care that they give our patients. It will impact their communication to us. And more importantly, they've not been around for the last 4 to 6 or 8 weeks to understand all the preparations that you have made for the COVID process in processing the patients. So they really need to be well informed as to the new protocols and guidelines that you have enacted at your site. So they just can't come in on Monday morning and think that they can just start working as they normally would. A lot of education and prep needs to take place and explain to them how you're going to work differently. How are we turning the rooms differently? How are we sending those case cards to Central Sterile before the patient is extubated? The case card is wiped down and then sent to Central Sterile. And then how do we wait to turn those rooms over? We go on automatic and we want to turn those cases over as quickly as possible. That's been our life forever now. But now we have to pause. We have to wait when it's necessary to not enter that room. We have to wait for the air exchanges. Sometimes those times are 18 to 30 minutes, depending on your site. So we have to caution and teach our employees, we're not going to go in there. We have to put up our signs or our tapes over the doors, do not enter, until it's safe to go. So all those things need to be in place before we bring those cases back. And there's a lot of work that needs to be done. So we have to prepare. We have to prepare the employees. We have to prepare the staff with the new rules and guidelines and our expectations for them so that they understand clearly. And then we have to talk about the experiences that the patients may have had, in the past 6 or 8 weeks at home with people being sick, with the experiences that they've had perhaps working in different departments, and the financial impact that is on themselves and their families. So, it takes a little bit of work as we come back to this new life that we have. So I just really wanted to mention that. We are leaders. We're here for our patients. We've always been there for our staff. But, it's a new day for us. it's new for all of us. So I think that bringing them in early and helping them to understand our new way of life is really essential. So I want to really thank you for being part of this today and thinking about how we need to prepare for this new road to recovery as our states are releasing our date that we can bring the elective cases back in. It will not be easy. It's just planning ahead of time, having protocols in place, explaining all of those protocols to our patients, and making sure that all of our teammates are on board with all the protocols, and ensuring that there is safe recovery for everyone and making it a great place again for our patients to come to. So thank you for being part of this presentation. We do have an opportunity for some questions, and we'd like to take those at this time if there are any.
That's right. Thank you so much, Ann and Yvette. You heard them. It's time for questions from our attendees. As a reminder, just enter the question through the chat box and click send. And again, your questions aren't viewable by the other attendees, but they will be received. And, we just wanted to let everyone know that if there are a lot of questions today that we aren't able to get to, Ann and Yvette and folks at Surgical Directions will be happy to follow up with people after the event via email. Okay, let's get to our questions. Question from attendee. During the presentation, when you say test caregivers weekly, are you referring to hospital staff?
Yes, we will be asking that and recommending that the healthcare providers be tested weekly as we go through. Our CDC will provide us guidelines to how long that should continue. Again, we will depend on our professional organizations to help guide us through that, but at this time they are recommending weekly testing of the healthcare providers.
Okay, thank you. Another question here. Is the checklist web-based or paper?
It is a document that you will be able to download and utilize yourself. So we will provide that to you so that you can print it out and work with it. And the checklist is a tool that you can use. It can be modified based on your needs at your clinical site. So yes, you'll be able to use it.
Okay, excellent. Thank you. Okay, another question we have is, how are hospitals using objective data to decide surgical priority rather than subjectivity of a committee?
This is where the governance structure comes into place, where you're going to use data along with your governing body to be able to make those informed decisions. But you should use data. We recommend that, and that's where Ann talked about earlier in the presentation how important it is to leverage your data analysts or the business managers of the surgical services unit so that you can look at that data, both your historical data and speaking with your surgeon's offices about planning. So it's hand in hand. You can't do one without the other.
Okay, great points. Thank you, Yvette. Let's keep moving ahead. Our next question is, are facilities performing COVID testing and quarantine prior to elective cases?
They are recommending that patients be tested within 48 hours of coming to the facility. If that's not possible in your community or your area, then patients will be screened first via phone call through that surgical preparation call, and should also, if it's done out greater than 48 hours, they should be called again to see how they're doing within that 48 hours of surgery. And then on the day of surgery at curbside, they will be screened and assessed. Their temperature will be taken. Their oxygen saturation will be taken via a finger probe, and we will be asking screening questions to see that their state of health and whether or not it is safe for them to come into the hospital and have their procedure.
Okay, we have some follow-up questions here on this topic. Let's make sure. One attendee says that they're requiring COVID testing prior to elective surgery, and that should eliminate the need, or should that eliminate the need to wait for the air exchanges? Is that correct?
No, you really need to, some of those tests are not 100% accurate, and depending on when the test was performed, but still with patient intubation and aerosolizing potentially the bacteria or the virus, it is recommended that you still comply with the air exchanges and waiting for the ventilation to clear. And that time frame is dependent on your facility air exchange rate.
Okay, and then again, another follow-up here regarding curbside testing. Are you assuming the facility has in-house testing capabilities?
I would say that each facility needs to plan on what they can and cannot do. Each facility and geographical area has capabilities, some more than others. You may not be able to do the testing curbside and wait, the 15, 20 minutes, maybe up to 30 to 60 minutes to get a test result if you can do it in-house. And you may be dependent on doing a physical assessment curbside in interviewing the patient, doing the temperature, the O2 saturation check to see that they are symptom-free. So depending on what you can do will be what you can do. Some sites will have the ability to do the testing on site and some will not. So it's totally dependent on what resources you have.
Okay, yeah, great points. And let's see here. Another question just in, for how many days in a row do you recommend patient testing be done? And is this for inpatient admits or outpatient surgery patients?
Well, all patients entering the hospital need to be screened prior to entry into the system. And I think that patients, I would have to refer that we go back to the CDC to confirm the timing, but I'm pretty confident that it is at least weekly that they're tested. But I really want to refer back to the CDC's recommendations on that.
Okay, excellent. And I think that this kind of dovetails with this next one. This question from an attendee says, are the new protocols for all cases or only those who are COVID or PUI?
Well, the safety protocols are for all patients entering the system, entering the hospital. So whether we know that they are COVID positive or not, or COVID suspected, or just a patient entering in that states that they're healthy and we think they're healthy, we still have to protect ourselves in not knowing that they could potentially have it. So these precautions are really for all patients, and we have to protect ourselves and our patients for COVID because we don't know. We just don't know. So yes, they're for all patients.
Okay, thank you. One attendee says you discussed pre and peri-op changes. What impact do you expect on the post-op stage?
Well, the post-op stage, it is recommending that you have the one nurse take that patient when they come out of the OR in the PACU and to try and have just the one caregiver for that patient if possible and not have multiple nurses. So often we have the stage 1 recovery and then we have stage 2 where we hand off to another nurse sometimes. And they're recommending that if possible, stick with that same nurse. So that same nurse follow them all the way through from entry into recovery to the discharge, giving the patient discharge planning and handing them off to their family in their car. So that is the recommendation that would require really sometimes more staffing and better planning so that you can do that. It is the ideal situation and it is the goal. It won't necessarily always be possible depending on how patients come through our ORs and depending on your staffing resources, but that is the goal, so it will be different. We also need to think about how we space our patients in our recovery room slots. How do we separate the patients so that they are at least 6 feet apart? How do we prevent patients from cross-contaminating? We do have isolation rooms in our recovery rooms. We have to plan ahead if we know that there are COVID patients that will be requiring surgery so that we do make sure that that recovery room is available for that patient. So again, pre-planning and talking with each other as to what patients are coming through and how we do it is essential. But recovery room will have to make sure that they have the space to take care of those patients, and then planning that space and planning for that patient sequence is important.
Okay, thank you, Anne. We still have more questions coming in, so we'll get right to the next one. You had mentioned turnovers will be longer because of the air exchanges, but what if the staff is wearing their N95 masks? Do we still need to wait for the air exchanges?
Yes, we do. Yes, we do. The staff, the anesthesiologist and the circulating nurse will have their N95s, when they're extubating the patient or intubating the patient. And no one else should be in the room during that. If anyone else is in the room, they should also have the N95s during that time. But it is truly recommended that we allow the air exchanges to fully take place and not rely on the N95 mask. It is really a safety initiative and important that we do that. The N95 masks are wonderful, and we do want to make sure that we protect the safety of our employees when we turn those rooms over. We know that some places are using masks for 5 days. We just don't have the resources to grab a new mask after every patient use. We want to make sure that they fit properly. It really is best practice, and it is the recommendation by AORN and CDC that we do allow the full air exchange to take place before we enter the ORs to turn the rooms over. So I would recommend that.
Okay, thank you, Anne. That's well said. Next question. Due to false negative COVID test results, would you recommend to treat all surgical patients as positive? And if so, how do you mitigate the PPE shortage?
Well, really it is the best way to take care of every patient the same way, to think of them as having, a positive case, because that's the best way to protect ourselves and not to assume that it's safe. Again, the reason that all the elective cases were put on hold for these weeks was to reserve our resources, to conserve and have those PPE items. I know everyone across in the world has been securing PPE and making sure that we have enough resources to take care of our patients and to take care of ourselves safely. And that really is the key in the planning stages. Our key leaders need to make sure that we have what we need, because these are elective cases that are coming on board, not the urgent emergent. We're embracing these new elective cases, and we need to make sure that we have the PPE to protect ourselves. And do we have to delay cases? Perhaps. It's hard to tell. But we do have to plan and know what our supplies are for masks and gowns and everything that we need.
Okay. Thank you. I have another insight here from an attendee who says, our OR is currently performing urgent and emergent cases, and I believe we're not following the recommended protocols that you present when resuming elective cases. How do we convince surgeons who have not been asked to change their practice to do so in the new COVID era? And this attendee notes that I am an OR manager who has been furloughed.
Always difficult to have situations where people are not in compliance with protocols, I would strongly recommend that your governance council be consulted as a group of these issues when they occur, that we include the chief medical officer of your hospital or your site and explain to them what is occurring. We need to really explain further to that physician or that staff member the purpose of the protocol and why it's necessary for all of us, not just that one patient, but for all the patients that are coming through the OR. It's important for all of us to be safe, and we have that right to be safe. So again, I would encourage you to use your governance council, your governance committee, work with your chief medical officer at your hospital, your infection control preventionist, your chief of infection control, and your administration if there are issues.
Okay, thank you, Anne. We have a few minutes left, so I think we'll take 2 more questions. What is the rationale behind having the recovery nurse also discharge the patient?
Well, the rationale has been explained that they want to decrease the amount of persons touching each patient. So we really want to decrease the amount of nurses in the recovery stage 1 and stage 2 from taking care of that patient. So often when we're working in, I'll just say stage 2 areas of recovery, and we're getting that patient ready for discharge, I may go help a patient get dressed, or someone may need to go to the bathroom, and I'll be happy to take your patient to the bathroom, or whatever needs to be done. I'm busy. I'll give your patient instructions. So sometimes we team and we take care of patients. But we're asking now that just one person be that contact, that physical contact with the patient, to decrease the possibility of someone catching something or transferring COVID to that nurse. So if we can eliminate multiple people from taking care of that patient, it's really just that one nurse that has been touched by that patient.
Okay, thank you. One follow-up. What about in an ASC where a low-risk case is done, no intubation, no upper airway surgery, for example, patient wore a mask? Low-risk surgery, so do we still need to wait for the extended ventilation time?
We still need to understand that we need to treat all patients as possibly they could have COVID, and we need to protect ourselves. We need to protect them. The ventilation precautions really are put in place when we need to intubate the patient, and we perhaps are aerosolizing the virus during that intubation process. So again, talk with your governing committee as to what you will be doing at your site. Many cases are not intubated cases, and you need to partner with your anesthesia partners as to what are the protocols for those cases and what you should be doing at your site, and comply with their recommendations.
Okay, thank you, Anne. And we just want to confirm these recommendations, are they coming from the CDC or other governing body or from someone else?
The recommendations come from several groups. They come from the CDC. They come from the American College of Surgeons, the Anesthesia Society, AORN. All of those societies and groups have put out guidelines and standards and recommendations, and all of those need to be considered. They can be consulted online. All of these recommendations and guidelines from these professional organizations are readily available. We have collated them on our checklist and update them as often as we can. It is a living document, and we are happy to share that with you and update it, and we will update it as it changes. So really seek out those professionals that are guiding us toward this road for recovery.
Excellent. I think that's a wonderful note to conclude on. We are at time, and I want to thank all the attendees for their fantastic questions and Ann and Yvette for a wonderful presentation. Again, as a note, this session has been recorded, and attendees will be able to access the recorded archive by using the same login information used today for the live webinar. And we wanted to also note, we have some questions about this. A copy of the presentation slides will be going out to attendees after the event. As we conclude for today's event, we also just wanted to remind our audience to please save the date for the OR Manager Conference in Las Vegas. And again, as we noted earlier, please be sure to check out our exclusive May issue. With that, have a wonderful afternoon, and you may now disconnect.